So, greetings, everyone. My name is Larry Cole, and I'm host of COVID Impact 360 Conversations. Today, I'm talking to Switzerland and Dr. Maja Strasser, and I'm pleased to have her here today. Hello, how are you?
Hello, fine, thank you. Thank you for the invitation.
Oh, my pleasure. I'm glad. So, the way I usually start this, Doctor, is I will explain to everyone like kind of how we met, which was quite simple, and then why we're here today. Um, so I started seeing Dr. Strauss commenting on LinkedIn and putting a lot of effort into her comments around COVID and long COVID and treatment and management, that kind of stuff. So I actually reached out to her and I wanted to say hello, and because I was just very impressed with her comments and what she was working on. So um, that's how we had an original phone call, and it was a fascinating phone call because of her heritage and her background and how she's in Switzerland. And I'm hoping that she'll share some of that because to me it was fascinating as all get out. So, um, and then from there, I'd like to go right into what you've been working on and really the theme of today's show. So thank you for coming on. Let's start with what is your background? Give us your background in medical.
Well, I'm a neurologist and I have my own medical practice since 2012. And it's in the northwest of Switzerland in a small town called Solothurn, which is a very pretty Baroque town. And it's between Bern and Basel. So, yes, I used to be just a kind of a general neurologist. And I didn't have any specialization in this field. And then the pandemic came, and well, I started to kind of specialize in long COVID and ME.
So how did you start to specialize? Because that's kind of where the story starts here, um,
Yes.
and that's so let's begin there because that's going to give some background to the rest of what you're working on.
Yes. So I was a foreign exchange student in Massachusetts, and there I got to know another teenager, and she had a very severe illness that I had never heard of, myalgic encephalomyelitis or chronic fatigue syndrome. And I was just very touched that such a young person is severely ill and there is no approved treatment. And then I returned to Switzerland. I became a doctor, and I realized that we really have a blind spot for this illness. And I think that in many European countries, it's a lot worse than in the US and in Canada. Because, in some countries, it's better. For example, the Norwegian health authorities, they have actually apologized to the ME patients for the lack of care years ago. But in Switzerland, there has been hardly any awareness, hardly any doctors know about this. And generally, we know that only 10% of ME patients ever get the correct diagnosis. And those 10%, they have a real odyssey behind them. And in Switzerland, there is a study by Job and Koenig, and they found that on average, it takes 7 years and 11
Wow.
consultations and 2.6 wrong diagnoses. And in 90%, they get the wrong diagnosis psychosomatic. And
Wow.
I don't know any other illness with such bad statistics. It's just a real horrible lack of health care.
So that took you. So how did you tie the ME into long COVID? Like were your patients like how did you like these are like I'm assuming that ME is also a post viral condition. If you
Absolutely,
yeah,
absolutely.
so
So, 10% of the persons with long COVID fulfill the diagnostic criteria for myalgic encephalomyelitis. So, 10% have this severe neuroimmunological illness. And the thing is, I realized quite late in the pandemic, only the first week of March, I realized that this was going such a global, huge problem.
Yeah.
But as soon as I realized that, I knew that we are going to have way more people with ME and similar diseases. And so the umbrella term is post-acute infection syndromes. And in the beginning, we had the wild type, and there about 20% developed long COVID. And now, for the last 2 years, it's Omicron, different types,
Yeah.
subtypes of Omicron. But we still have about 5 to 10% risk of long COVID, which of course is a lot because, you know, in most countries we don't have any measures anymore. And so we have a lot of infections, and 5 to 10% of them are left with long COVID. And some recover in the first couple of months, but many just linger on and get severely ill.
Yeah, well, yeah, no kidding. And for interest's sake, 10% in some people's minds may not sound like a big number, but when you start considering the millions of people that have gotten COVID and then
Mhm.
take 10% of that number, now you're talking a real number. And the last statistics I heard, which was actually the beginning of this week, was we're between 450 and 500 million people with long COVID. So
Absolutely.
so
Absolutely.
you start talking, well, that means that there's been 5 billion people infected
Mhm. There is
with
even
COVID.
a Harvard study. They analyzed 300,000 patient histories with artificial intelligence. And they had a very clever design because they analyzed people who had a viral infection, I think it was 2017, so well
Mm-hmm.
before the pandemic,
Yeah.
and compared them with people who had COVID-19. And the study was done in Massachusetts, and it ended in spring 2024. And they came up with a number of
Yeah.
22.8%.
Yes. I saw that.
And
Yeah.
that is really scary. And I think, I mean, I know in Switzerland it is very much underdiagnosed. And I looked up last month, I diagnosed long COVID or ME/CFS in 7 patients who were sent to me with completely different problems, with headaches or exhaustion or sleep disorder, and they all turned out to have either long COVID or ME/CFS.
So that's a good segue, actually, because you're doing something unique in your practice. I believe you're doing something unique. I think that's what got us talking was. So, how did you go about diagnosing them with long COVID? What's your process?
Yes. So, the key symptom of long COVID and ME/CFS is the post-exertional malaise, because everybody's talking about fatigue, but this is actually the least specific symptom. You have fatigue with tumors or multiple
Hmm.
sclerosis and so on, but this deterioration after overexertion, and it only begins 1 to 3 days later. This is so typical. And for example, just the day before yesterday, I diagnosed a teenager with long COVID, and she is very, very sporty. She's very ambitious, and she started having severe headaches 4 weeks ago, and they started one day after a soccer match. And then they were similar to migraines, but they didn't respond to any typical migraine medication. And migraine, they typically have a hypersensitivity to stimuli, to light and
Yeah.
noise and scent. But in her case, it was extreme. I mean, it was really bad. And then she got a little better and did sports again. And 2 days later, the headaches got worse again. And I mean, this is post exertional malaise. And so, generally, if I see people who have either muscle pain or headaches or nausea and just generalized malaise, they're not feeling well, or gastrointestinal symptoms after overexertion, I always think of that. And nowadays people don't test anymore. So she had a severe high fever with a sore throat in the summer. And this might have been COVID, or you can even get long COVID after an asymptomatic infection. But
Yes.
nowadays, very often people don't know whether they have had COVID or not.
Oh, you just said a mouthful because I run into an awful lot of people that of course don't follow this as closely as somebody like yourself or myself as well, and they'll say to me, I've never had COVID, and my first question to them is, how do you know?
Mhm.
Well, I wasn't sick, and I said, well, no, fair enough, but people don't really people don't tie asymptomatic to I might have had COVID, and then uh, this is where I'm kind of leading with my comments here is that, of course, one of the leading causes of long COVID is getting multiple infections of COVID. So I always think of it as being, you can be infected once, twice, three times, have asymptomatics, and then that fourth infection is what takes you over the top. And there's no rhyme or reason or previous test or future test. It's just one of those things.
Mhm.
Um, Comments about that, because that's an area that a lot of people have a hard time with.
Yes. I mean, I see a lot of patients who had two or three COVID infections and were all fine. And then, or for example, I have a patient, he had three or four COVID infections, and it took him longer and longer to recover from that. And then he had influenza A, and that just tipped him
I
over. So,
Yeah,
I
yeah,
mean, it's in about two-thirds. ME is triggered by viral infections.
right.
And of course, the first description of ME under this name was in 1956 because there was a severe breakout in London, and this illness is acknowledged by the WHO as a neurological illness since 1969. So that's a long time ago. And there are several different triggers. I also have patients, for example, who were triggered by giving birth or by having an accident. But it's really at least two-thirds are triggered by viral infections. And it can be EBV, Epstein-Barr virus, it can be influenza, or of course SARS, SARS-CoV-2.
Yeah, that's interesting because I got flu last year, and it knocked me on my butt because I had had COVID and then long COVID, and then this flu came along, and boy, it was. And I mean, this isn't about me, but you're as soon as you were talking about influenza being a kicker, I instantly related to that. So here we are. You have a patient, and you've diagnosed them. Where do you take it? Where do you take it from here? Okay, I've got long COVID. This is what was the real genesis of this call today, is that you have a unique set of protocols. And do you mind if I use that word? Do you mind if
Yes,
I? Okay.
yes, perfectly
So
happy.
so you've got a way of managing this process once you're happy with where you think that patient's at. Can you talk about that?
Yes. So what I did is I analyzed the current recommendations by top experts. And, it was very difficult to get into this field because this is a very complex illness. And
Hmm.
also, there is no approved treatment. So you usually have to try different things. And, there is no approved treatment, but for ME, there have been treatment strategies for decades, which have been proven very effective. And they also work for the ME form of long COVID. So, with fatigue, exertion intolerance, post exertional malaise, they usually have also orthostatic intolerance, so they don't tolerate being upright, and cognitive disorders. And what I did is, among all those recommendations, I identified 4 things that you should absolutely address. And so these make up the core of my treatment protocol. And this is where I start. And then you can always treat specific symptoms or you can escalate treatment. But in every single patient, in every first consultation, I start with those 4 things.
So what are they?
Yes. So the first is pacing. Then the second one is postural orthostatic tachycardia syndrome. I'm going to explain later what this is.
Okay.
And then histamines and avoidance of reinfection. So PPHR, or perfect punks honor rebels. You can
Okay.
memorize it like
Yes, you
that.
can.
Okay.
Yeah. That's very
So
good.
yes. So the first aspect is pacing. I told you before that when they do overexertion, and this can be physical, this can be cognitive, this can be emotional, or also too many stimuli, they experience a deterioration, and this only starts usually with a delay of 1 to 3 days. And this is called post exertional malaise. And this post exertional malaise can last for days, weeks, but it can be irreversible. And in fact, there is a
Okay.
study by Holzmann and Batia, and they found that 67% of ME patients have had an irreversible post exertional malaise. That's a lot. So
That's
this is
really
not,
high.
yeah, this is not just a fear and irrational, but this is very, very rational. And this is really a danger. And if they overexertion on a regular basis, they just get worse and worse. It's like quicksand, you know?
Okay.
So they should really stay below the threshold, which leads to overexertion. And that is difficult because, as I said, the post exertional malaise only starts later, and it can be triggered by physical and emotional and cognitive overexertion, and also by stimuli. So, and of course, all of them together. So you cannot go to your limit physically and then I don't know, read half an hour. It's already too much. So if you, for example, do something in your household, then you have to reduce somewhere else. And this threshold can be extremely low. So there are really people who are bedbound. And then the second P is postural orthostatic tachycardia syndrome.
Wow.
And yes, this is a dysregulation of the autonomic nervous system. So if people get up, the heart rate shoots up way too much. And for example, they might have a heart rate of 145 or 150 just by ironing a few minutes or by brushing their teeth. And this is not normal. I mean, I have a heart rate like that when I jog quite quickly. And of course, I get exhausted after a while. I have to slow down, you know? So
Mhm.
if you have such a heart rate while brushing your teeth, you're going to feel awful. And you don't necessarily feel this as tachycardia, as heart throbbing, but you usually feel fatigue, weakness, dizziness. You start to sweat. You feel nausea and headaches and brain fog. So the symptoms are non-specific. And
Okay.
so you really have to ask for this. And doctors tend to underestimate this exertion intolerance, and they tend to overestimate the patients because, you know, a patient might say, I hardly leave the house, or they might say, I have a wheelchair. And the doctor sees the patient and thinks, well, today she left the house, she's here, or they think, well, she can walk, why does she have a wheelchair? But they don't see that maybe 1 or 2 days later she is bedridden in horrible pain because she did too much going to that doctor. Okay, so you really have to ask for post-exertional malaise. And I usually ask, for example, how many hours are you in an upright position? Or how often do you have the energy and the strength to wash your hair? And it might be that, they haven't washed their hair for months because they
Right.
deteriorate so badly afterwards. And this post-exertional malaise, this postural orthostatic tachycardia syndrome, 80% of long COVID patients have this. So you should really look for that. And I'm always happy when a patient has POTS because then I have more opportunities to treat. And the way you treat this is, first of all, with non-medical treatments. So you have to drink 3 liters a day and have a salt intake of 8 to 10 grams. And you should also try half a liter of broth in the morning, because in the morning you are dehydrated. And if you just drink fluids and don't take any salt with it, you cannot retain this. So, and so if you drink fluids with lots of salt, you can keep this in your body and it gives you like a head start into the day.
Okay.
And also, you can try isotonic fluids. There's also a special mix for babies who have diarrhea. So, oral rehydration solution, it's called. So, you can try something like that. Also, compression stockings are very helpful. And in the summer, cold foot baths. And then I treat POTS quite aggressively with drugs because people really benefit from that. And in people with a normal blood pressure or even low blood pressure, the drug of choice is ivabradine. And ivabradine was actually licensed for people with cardiac insufficiency, so something entirely else. So this is off label. And there is an advantage over beta blockers because beta blockers decrease both the heart rate and the blood pressure. And with
Mm-hmm.
ivabradine, you only treat the heart rate. So
Okay.
most people tolerate it better. I don't know whether it's available in all countries. It's certainly more expensive than beta blockers. But many patients are young women and they have a low blood pressure anyway. And if you give them beta blockers, they're going to feel even worse. So that is really important. And the way you diagnose POTS, you don't need a tilt table for that. You can just do a NASA lean test. So like the NASA, which shoots the
Yeah.
astronauts to the
Yeah.
moon. So the NASA lean test is that the patient has to be resting for a long time because a lot of people with long COVID, they have such a dysregulation that it takes them 1 or 2 hours or even more to reach this resting steady state. So they should really rest for a long time and measure heart rate and blood pressure. And then they have to get up and lean on a wall and again measure heart rate and blood pressure for 10 minutes every minute. And if the heart rate goes up by more than 30 a minute, and with teenagers more than 40, they have POTS. So that is really
Okay.
crucial.
Okay. Yeah. That's
So,
very
and
cool.
then the age, that is histamines. A lot of long COVID and ME patients have mast cell hyperactivity or mast cell activation syndrome. And the mast cells are actually kind of like allergy cells, and they release histamine. And either because of certain foods or just for no reason whatsoever. It's just like a mistake of their body. So you can diagnose this, but it's quite hard to do the lab and urine results. And I think it's way easier to just try antihistamines for a couple of weeks. And in Switzerland, we don't have H2 blockers anymore. They were used against gastric ulcers, but now we have more modern drugs, so unfortunately they are not available anymore. But if you have famotidine or cimetidine, I would certainly try one of those. And I would also try some like anti-allergy, anti-hay fever medication. And I usually use fexofenadine because it has little side effects on the heart. Because
Okay.
there are others like desloratadine, but they're a little less tolerated. And then the last thing is avoid reinfection. The thing is that you have 80% risk of deterioration if you get COVID-19 again. 80%. That's a lot. Because these people,
Wow.
they just have this uh, genetic makeup which makes them vulnerable to infections. So it's and even if you have fully recovered from long COVID and you get reinfected, you have 60% risk of getting long COVID again. So, it's really crucial that they protect themselves from reinfections. And those viruses are spread by aerosols. And I always explain that it is kind of like smoke, except you don't smell it. But it's like smoke. And you can go into an empty room, and if somebody with COVID used this air 1 hour ago, you can get sick. Because people always think of crowds, but you don't have to be in a crowd. You can go to
Yeah.
in
Yeah.
an elevator and
Yeah.
get COVID. So, what is really protective are respirators. So, for example, FFP2 respirators, not the surgical masks. And also, you should have clean and healthy indoor air. So use HEPA air filters
Yeah.
and open the window very
Yeah.
frequently. And you
Yeah.
can also monitor the quality of air with CO2 monitor. And I highly recommend this Aranet 4, which is an excellent device and it's not so expensive. And so, for example, this is 644 ppm CO2, which is excellent quality of air.
It's
So,
it's funny.
all in all, it's four things.
Okay.
So, pacing, postural orthostatic tachycardia syndrome, and histamines, and avoid reinfection. Or again, perfect punks honor rebels.
Really like that acronym because I can remember that. Just going back to your air for a moment, I've actually got two of them in my home,
Mhm.
and I keep them the HEPA filters on full time. There, I was reading a study recently about. I think one of the worst countries in the world for reinfection of all places is Australia. They're one of the leaders in people with multiple infections, like 5 to 10 infections. It's almost like they're just going in this big loop and they can't get out of it. So when I think of your protocol, one of the things that was lost, I think, and I just want to change tactics here for a moment. One of the things that was lost in the politics of COVID was we stopped two things. We stopped being safe and we stopped counting. Two of the most ludicrous things that you can think of. And it really shows how disinformation can really drive stupidity
Mhm.
because
Mhm.
now we're not, we really have relied upon sewage treatment testing to try to get numbers, but we don't have accurate numbers around the world. Some places do, some places don't. And the other thing is just the obvious things around air. I mean,
Mhm.
I see the people that are pushing hard for getting schools with better air systems, getting hospitals with better. I mean, the hospitals are fine, but then it becomes a question of how quickly can you change your filtering, and just there's some common sense in all of this that seems to get lost in people's pseudoscience. Um, Go ahead.
I fully agree. And, for example, in Switzerland, one newspaper has measured the quality of air in classrooms, and they had measurements of 3,500.
Yeah,
And that is just crazy.
yeah,
And with those measurements, I think that's about 8% of the air which is used. So every 12 breaths, you have a
yeah,
full lung
yeah,
volume of used air. And I
yeah.
mean, you wouldn't drink water which has been thrown up, right?
No,
So
exactly right. Yep.
and I
Good
mean,
point.
I also think that where should we protect vulnerable people if not in a healthcare setting, if not in schools, universities, and workplaces, but especially in healthcare settings?
Yeah,
And, I mean, we have so many highly vulnerable people, and a lot of them are not even aware that they are so vulnerable, but that doesn't make it any better. But
no,
they cannot go anywhere safely. They cannot go to the doctor, they cannot go to a hospital or to a pharmacy, and that is just not right. And it's
no.
also a human rights issue, actually.
Yeah. You know, one of the things that struck me in our first conversation when we got on our Zoom call was, and you may not know that you actually affected me this way, but I'd like you to talk about what it's like to practice in Switzerland as a female neurologist with long COVID. Because I'm not sure that a lot of people appreciate that this is not a straight line. This is not everybody accepting everybody. That was part of the story that kind of struck me pretty quickly.
Mhm.
Do you mind talking about that?
No, I'm fine. I mean, I had experienced quite a bit of sexism at hospitals, and so that was one of the reasons why I wanted to have my own medical practice. And then I was fine. Many doctors referred to me and I was appreciated. My practice went very well. And then I started with this long COVID. And, I mean, this treatment protocol is pretty unique. I have never seen anything like this. But long COVID is, at least in Switzerland, it is very politically charged. And I mean, this is science. It shouldn't depend on what political leanings your doctor
Can
has.
you explain that though? Can you explain where those lines are between politics and science in Switzerland? Because
Mhm.
that's something that I'd like people to hear.
Yes. So in Switzerland, the biggest political party is this Swiss People's Party, and they are very right wing. I mean, they're really they are against the state interfering with anything, and they're extremely anti-science. And they just want to rely on common sense, and they attack professors and
Yeah,
universities, and they're really anti-science. And so very early, they just rebelled against any protective measures, and then also there are a lot of rather left wing but very esoteric people, and they are also anti-science in a different way. And so in Switzerland, there is a lot of anti-science. And for example, compared with other European countries, the three German-speaking countries, so Germany, Austria, and Switzerland, have the lowest vaccination rate of COVID-19 compared with other Western European countries. And the government, the Swiss government, they really wanted to eliminate the pandemic in the first wave. And they did quite a good job. We never had a strict shutdown, but we never had a lockdown, but we had a shutdown. So we were allowed to leave the apartment and so on. But, and by May 2020, we really had the pandemic under control. And then I think for populist reasons, they just decided, okay, we are not going to listen to scientists anymore because at the end of the day, it's us politicians who have the responsibility. So we are making the decisions. And then they just, they allowed pop concerts and festivals and everything. And the second wave was actually the worst in
Yes.
all of the
Yeah.
world. And this is
Yes.
one of the richest countries. And we had it under control in May. And, they kept telling us this is just our way to do it and it's better for the economy. And of course, it's not because, I always compare it. If your Christmas tree is burning, then you wouldn't say, oh, it's expensive to extinguish the fire, and the water also leads to damage, and it doesn't burn in the neighbor's apartment, and they're watching TV. We don't want to bother them. Of course, you extinguish as soon as possible and completely. And what Switzerland did is they didn't quite finish this extinguishing, and they just let it rip afterwards. And in I think January 21, the situation became really bad, and most elderly people died in elderly citizens' homes. And uh, it depends on the region, but 25 to 50% of the COVID deaths died in senior citizen homes.
Yeah. Yeah.
And they just,
Yeah.
they wouldn't even be sent to the hospital anymore. And also that winter, 30,000 surgical interventions were postponed because of that. And to you, it might not sound like a
No,
lot,
that's a
but
lot.
Switzerland is a small country, so
Right.
it is a lot. And I had patients who had severe back pain and needed surgery, and just the doctor told me we cannot do surgery because we don't have space in,
Yeah.
so it was awful. And I mean, this second wave, I really have to say I was quite traumatized because people were feeling so bad. And every day I had patients who, for example, one patient, her mother was struggling for her life for 3 months because she had severe bleeding from the bowels, and they had to remove almost all her bowels. And and she was a mother of 3 children with her mother so severely ill. And I had patients mourning for her partner or maybe for her grandfather. And I also had people with severe financial problems because, I mean, of course, a shutdown or a lockdown is bad for the economy, but letting it rip is also terrible for the economy. And for example, there was a woman, her husband has a restaurant, and next week it was her daughter's birthday. And she was crying because she was afraid of that birthday because she can't buy presents.
Yeah.
And this in one
Yeah.
of the richest countries of the world. And I was
Yeah.
just, it was heartbreaking for me. And I mean, I have a lot of experience as a doctor, and I had never seen such a huge load of horrible stories just every day. And one evening I was just sitting there and thinking, when is this going to end? I mean, it was
Right.
awful. So, but the Swiss people were told that this is just the way we do it, and this is excellent for the economy, and it's only old people and sick people who are dying anyway, which I think is a cruel statement. And
Yeah.
so this is very politicized. and I think it shouldn't be, because there are facts, and 1 + 1 = 2, whether you like it or not.
Yes.
So, and then I published my protocol, and more and more patients started pouring in. And, I heard that other doctors say about me that I'm a quack and that I'm a liar and I'm just a greedy person doing this for money and fame. And I mean, you would be pretty
Yeah.
stupid if you were doing this for money, because it's so much work and I can't even charge everything I'm doing for these patients. So,
Right.
I mean, this would
Yeah.
be very stupid. And I think it's also because I'm a woman and I'm not white, and I just think, with an elderly white male professor, I don't think they would say such things, but I cannot prove it. It's just
Yeah.
my sentiment.
Well, and as you say about your heritage, this is the other thing that I found very interesting. So, what's your heritage?
Yes. So my mother is Japanese. She's from the island of Shikoku, and my father is actually German, or used to be German.
And you're in Switzerland.
Yes.
I just find all of that just delicious. It's just an interesting combination, and so when you and I were talking on our Zoom meeting, I talked about what do you want your practice to look like moving forward? Are you interested in getting involved with telemedicine? Because I have a feeling when people find out about your protocol that you're going to get some calls that are not from within Switzerland. You're going to get some people getting in touch with you that are outside of Switzerland because people need help.
Mhm, mhm.
And
I'm actually considering that. And I
yeah,
already do telemedicine in Switzerland.
sure.
And I also have, for example, a Swiss patient who lives abroad. So
Okay,
technically
okay.
it's possible. And I'm certainly considering that. So that's a possibility. Yes.
Because I see this as and I think you do as well. It's a global problem, and I think it's fair to say at this particular moment that you're not telling everyone that your protocol is going to work 100% of the time. It's your process and
Mhm,
how you manage this, and you sound like you're fairly aggressive at this, which is what I think some people need to hear that part of it because they think that they just feel hopeless, and I think you
mhm,
give hope fairly quickly. So the whole idea of being able to get in touch with you is what I want to leave people with in my blurb about this when I post the video. Are you afraid of people knowing that you're doing this, or are you open to that, or is there another way that they should work through before they talk to you?
No,
What's
I
it
mean,
like?
I could give medical advice online. What I
Yeah,
cannot do is, for example, getting involved in legal fights with,
yeah,
with
yeah, yeah,
insurance
yeah,
companies,
yeah, yeah,
or also, for example, I cannot send medication abroad,
yeah,
or I mean, people would have to check whether this drug or this treatment is available in their country. They
yeah.
have to do that themselves. And
Of
also,
course.
I can just send a Swiss prescription, but whether this is valid in another country, I
Yeah,
cannot
yeah,
explore
yeah.
this.
I, I,
But
th- I
of course, I could certainly give medical advice. Yes.
because that's going to be the key here is I think you setting yourself up where you have you have your protocol, but then there's a platform that people can work through in order to talk to you directly, make appointments and that kind of stuff. Because I would just hate to see somebody just start hitting your inbox with I'm sick, can you help me kind of stuff, because that can be overwhelming as well. So I just want to be careful when I'm posting about you. So maybe I'll talk to you about that offline, about how people can reach out to you where it's not overwhelming your inbox.
Yes, I mean, I have no idea what to expect, and but of course, my day only has 24 hours, just like
Yeah,
anybody
yeah,
else's.
exactly.
Although there
Yeah,
are rumors to the opposite, but it's not true.
I know.
But I mean, if I have capacity, I can take patients from abroad, if I don't, then I can't.
Yeah,
And
yeah.
so I can't promise anything.
So, do you have final thoughts in terms of big picture? Have we missed anything today that's an important part of your story, your narrative, and what you're doing moving forward? Have I missed something? Uh,
Well, I would like to point out one thing, and that is really everybody can contribute to protecting vulnerable people. So wear a mask. At least, there is a slogan, see a mask, wear a mask.
right.
And especially don't harass people who wear masks because you don't know what is behind this story. And
Yeah.
also, for example, if you visit somebody, especially maybe an elderly person or somebody who has had long COVID, you can always do a test and also wear a mask, and if you are sick and feeling under the weather or feeling like you have a flu, please stay at home and don't spread it to other people.
Yeah. Yeah.
And just all we want as allies and as long COVID and ME patients is adequate medical care. We are not
Yes.
asking for VIP treatment, but
Right.
just because there is no approved treatment doesn't mean that you can't do anything. So
Oh, hugely. Yeah.
yeah,
Yeah.
so we just really want to get adequate treatment. And also, a lot of people are, the COVID cautious people are very upset about how this is all going. And in Japanese, there is an expression for moral injury and the hurt and the pain this evokes, hifun kogai. And this is a kind of anger when there is overwhelming injustice. And so what I do is I feel Hifun Kogai a lot, but I try to channel this into positive action, and we can all do something. So protect vulnerable people. And also, I mean, if you have the capacity, you can reach out to the local long COVID patients organization, and I'm sure they need help or they need financial support, but we can all do something.
Fabulous message. And by the way, that was a very cool backdrop you did on the Japanese. That's and I didn't realize it until you started saying it, but that's kind of the way I feel. Is that
Mm,
we've sort of lost some humanity in all of this. Like you said, like don't give somebody a bad time because they're wearing a mask. That's their choice.
mm,
And I think that's where we've kind of lost our North Star in a way, in that this is about kindness. This is about
mm,
trying to keep people well.
mhm.
Um, but your protocol is something I want to get out there. So I thank you for your time today a lot. I think all of these people like yourself who have put a lot of time into this and haven't been paid. I mean, and then have to deal through the politics of it. I don't know how you do it. I'm kind of lucky because I don't have to deal with that. But I do meet a lot of people like you who have to fight through in order just to help people get well. So thank you for your time today.
Thank you so much. Thanks.
You take you take care.
Thank you.